Hi, so our next topic is uveitis. Now we learned the anatomy of uveal tract, so it will be easy for you to understand uveitis. Uveitis, the term uveitis strictly means inflammation of the uveal tissue only. So uveal tissue, what all things will come in that uveal tract, we already seen. There are three parts in uveal tract: iris, ciliary process, ciliary body, and choroid. So these are the three layers of uveal tract. So the inflammation of these three parts of the uveal tract will come under the term uveitis. However, practically there is always some associated inflammation of adjacent structures such as retina, vitreous, sclera, and cornea. So, practically there is always some associated inflammation. That means around structures there will be inflammation of the adjacent structures such as retina, vitreous, sclera, and cornea. Due to close relationship of the anatomically distinct parts of the uveal tract, the inflammatory process usually tends to involve the uvea as a whole. When we learned the anatomy, we saw, right, the iris anterior layer will continue as the anterior layer of the ciliary body, and then that will continue as the anteriormost layer of choroid. Like that, there is an anatomical continuation in the structure. So because of this close relation in the distinct parts of uveal tract, the inflammatory process usually tends to involve the whole uveal tract. So next, the classification of uveitis. Uveitis, first one is anatomical classification. Anatomically, uveitis can be classified into anterior uveitis, and it can again classified into iritis, iridocyclitis, and cyclitis. And the next is intermediate uveitis, posterior uveitis, and pan-uveitis. So uveitis can be divided into anterior, intermediate, posterior, and pan-uveitis. In that, anterior uveitis can be classified into iritis, iridocyclitis, and cyclitis. Iritis means that will involve only iris. Iridocyclitis means both iris and ciliary body, and cyclitis means ciliary body. So this is the anatomical classification of uveitis. Uveitis can be classified anatomically into anterior, intermediate, posterior, and pan-uveitis. And again, the anterior uveitis can be divided into iritis, iridocyclitis, and cyclitis. Next comes the clinical classification. Clinical classification depending on the clinical presentation of the disease. So uveitis can be classified into acute uveitis and chronic uveitis. And next is pathological classification. Pathologically classification, uveitis can be classified into separative and non-separative type, or purulent or non-purulent type. Again, this non-separative type can be classified into two, granulomatous and non-granulomatous type. So this is the pathological classification. First we mentioned anatomical classification, then clinical classification, that is acute and chronic, and next comes the pathological classification. In that, separative and non-separative. In that again, non-separative can be divided into two, granulomatous and non-granulomatous uveitis. And next type of classification is etiological classification or Duke Elders classification. It can be classified into infective uveitis, allergic uveitis, toxic uveitis, traumatic uveitis, uveitis associated with non-infective systemic diseases, and idiopathic uveitis. So this is also the etiology of uveitis. So etiological classification, depending on the causes, we can classify uveitis into infective uveitis, allergic uveitis, toxic uveitis, traumatic uveitis, uveitis associated with non-infective systemic diseases, and idiopathic uveitis. So this is the classification of uveitis. So uveitis is nothing but the inflammation of the uveal tract or uveal tissue. Due to the anatomically very close, there is a chance of getting all the parts of the uveal tract involved in this uveitis. So there is an anatomical continuation in iris, ciliary body, and choroid. So the chance of spreading of inflammation is more. So next we learned the classification. That first is anatomical classification, that anterior, intermediate, posterior and pan-uveitis. In that anterior again classified into three: iritis, iridocyclitis and cyclitis. Next comes the clinical classification. Depending on the clinical presentation, it can be classified into acute and chronic. And next comes the pathological, that is divided into two, that is separative and non-separative. Again, non-separative is classified into granulomatous and non-granulomatous. And etiological classification, that is also known as Duke-Elders classification, that is infective, allergic, toxic, traumatic uveitis associated with non-infective systemic disease and idiopathic uveitis. Next comes the etiology of uveitis. So now we learned uveitis classification. Now comes the etiology, causes for uveitis. That is same as the Duke-Elders classification. Despite a great deal of experimental research and many sophisticated methods of investigation, etiology and immunology of uveitis is still largely not understood. So there is some confusions in this etiology and immunology of the uveitis. So, the etiological concepts of uveitis as proposed by Duke Elder in general are discussed here. That is same as the etiological classification of uveitis. So, first comes in that is infective uveitis. In this, inflammation of uveal tissue is induced by invasion of organism. Okay, so infective uveitis. So there will be invasion of organisms to get infected. Uveal infection may be exogenous, secondary, or endogenous. So this infection may be exogenous, secondary and endogenous. So first one is exogenous infection, wherein the infecting organisms directly gain entrance into the eye from outside. So this organism will come from outside, that will enter into the eye from outside. It can occur following penetrating injury, perforation of corneal ulcer and post-operatively after intraocular operation. So, there is a direct entry of organism into the eye. This may occur due to penetrating injury, any injury that will penetrate inside the eyes, or perforation of the corneal ulcer, that we learned, right? While we learned corneal ulcer, we saw perforation of corneal ulcer. There is a perforated, there is an opening, so organisms can go inside. And post-operatively, after any surgery, intraocular surgery, eye surgery, also there is a chance of invasion of organism into the eye. Such infections usually result in an acute iridocyclitis of suppurative nature. So, if it is like this, that infective uveitis mainly causes acute iridocyclitis of suppurative nature, which soon turns into endophthalmitis or panophthalmitis. That means it will affect the complete eye, endophthalmitis and panophthalmitis. So that is exogenous infection. The organisms will directly enter into the eye from outside. That is exogenous. Next comes secondary infection. Secondary infection of uvea occurs by spread of infection by from neighboring structures. So there is a chance of getting infected from the neighboring structures into the uvea. Example, acute purulent conjunctivitis, pneumococcal or gonococcal, keratitis, scleritis, retinitis, orbital cellulitis and orbital thrombophlebitis. From any of this, there is a chance of getting spread to the uveal tissue and can cause uveitis. That is secondary infection. Third comes the endogenous infection. Endogenous infection are caused by the entrance of organism from some source situated elsewhere in the body. The infection is there elsewhere in the body, but through the bloodstream it will reach uveal tissue by the way of the bloodstream. Endogenous infections play important role in the inflammation of uvea. So here it's a vascular coat of eye, right? So highly vascular, so there is a chance of getting this is more in case of uveitis. So endogenous infection will be more. So these are the three sources of infective uveitis. First one is exogenous, from outside directly. It can be due to any perforated injury or due to the perforation of cornea in corneal ulcer or due to the post-operation intraocular surgery. Second is the secondary infection from other structures. Secondary, we can get this uveitis from the retina, conjunctiva, etc. And third one is endogenous, that is from other part of the body. Through the bloodstream we can get infected uveitis. There is a chance of getting uveitis, that is endogenous infection. And types of infectious uveitis, that depends on the causative organisms. The infectious uveitis may be classified as follows. That can be bacterial, that is granulomatous, and it can cause due to tuberculosis, tubercular, leprotic, syphilitic, brucellus or pyogenic structure, streptococci, staphylococci, pneumococci and gonococcus. Bacterial infection. Viral infection, that may be due to herpes simplex, herpes zoster, cytomegalo inclusion virus, etc. And can be fungal. Fungal can be aspergillosis, candidiasis, blastomycosis, etc. Or parasitic through that is known as thromboplasmosis, toxoplasmosis, toxocariasis, onchocerciasis, and amoebiasis. And also rickettsial uveitis. Rickettsial uveitis may be occur in scrub typhus and epidemic typhus. So these are the types of infective uveitis: bacterial, viral, fungal, parasitic, etc. Next comes the allergic uveitis. Allergic uveitis is hypersensitivity link. This is a commonest occurrence in clinical practice. So this allergic uveitis can be through microbial allergy. So microbial allergy, in this primary source of infection is somewhere else in the body, and the escape of the organisms or their products into the bloodstream causes sensitization of the uveal tissue with formation of antibodies. So here what is happening, microbial allergy, the organism or that bacteria or virus will be in other part of the body. It can escape from there through the bloodstream. It can reach uveal tissue, or the toxins secreted by this organisms can reach through the bloodstreams through this uveal tissue, and there it causes the formation of the antibodies. Primary focus of infection can be a minute tubercular lesion in, this is example. So primary focus of infection can be a minute tubercular lesion in the lymph node or in the lungs, or other sources are streptococcal and other infection of the in the teeth, paranasal sinus, tonsils, prostate, genitals and urinary tract. From here and all, that is the primary source of infection. From there it can the organisms can come, that is microbial allergy. Organisms can come, or the secreted byproducts can come through the bloodstream and reach this uveal tissue. Next comes the anaphylactic uveitis. It is said to accompany the systemic anaphylactic reactions like serum sickness and angioneurotic edema. It will be associated with anaphylactic reactions. Atopic uveitis. It occurs in airborne allergens and inhalants like seasonal iritis due to pollens. A similar reaction to such materials like danders of cat's danders, chicken feather or house dust, egg albumin and beef proteins, and also noted causing atopic uveitis. And autoimmune uveitis, it's with autoimmune, associated with autoimmune diseases like rheumatoid arthritis, vaginous granulomatosis, systemic lupus, erythematosus, writer's disease, and so on. So these are the reasons for, one more is there, HLA. So these are the reasons for allergic uveitis. So the first one was microbial allergy, then anaphylactic uveitis, atopic uveitis with seasonal returns and all, or the danders of cats, chicken feathers, or even house dust can cause uveitis. And autoimmune disease associated with autoimmune diseases, and also in HLA associated uveitis. HLA means human leukocytic antigen. It's the old name for the histocompatibility antigen. Histocompatibility antigens play an important role in our immune system. So these antigens, HLA antigens, can be seen in almost all our cells. These will decide whether these will inform our immune system that the protein which is seen in our bloodstream is our own protein or from the foreign bodies, foreign organisms like virus, bacteria, their toxins. It is decided by this HLA. So HLA is humoleukocytic antigen. So this is the histocompatibility antigens, and this play an important role in a immune system. So there's few examples which will disease, HLA associated disease which will cause uveitis are HLA-B27, that is associated with ankylosing spondylitis and also in Reiter's syndrome. HLA-B5 uveitis in Behçet's disease, and HLA-DR4 and DW15 Yokoyanagi-Haradas disease, and these are the diseases which is related with the HLA. Okay, so this will cause uveitis. This will also come under allergic uveitis. So in allergic uveitis, first one was microbial allergy, then anaphylactic, atopic, and then the autoimmune allergy, and then this HLA related diseases. So first one was etiology was infective, second one was allergy, and third one is toxic uveitis. Toxins responsible for uveitis can be endotoxins, endocular toxins, and exogenous toxins. So endotoxins are produced inside the body, play a major role. These may be autotoxins or microbial toxins. Toxic uveitis seen in patients with acute pneumococcal and gonococcal conjunctivitis and patients with fungal corneal ulcer is thought to be due to microbial toxins. So this is, as we mentioned, as we discussed before, endotoxins means it is there inside the body. It can reach through the to the uveal tract. So it can be the toxins secreted by the microbes or autotoxins itself. Endocular toxins means that are produced in the ocular tissues, from the ocular tissues itself. So uveitis is seen in patients with blind eyes, long-standing retinal detachment, and intraocular hemorrhage. Hemorrhage inside the eye is said to be due to endocular uveitis. Endocular toxins, they are endocular toxins that will cause uveitis. And other examples are tumors and phagotoxic uveitis. And next one is exogenous toxins. Exogenous toxins is from outside. So irritant chemical substance of inorganic, animal or vegetative origin. Certain drugs also produce uveitis, such as myotics and cytotoxic drugs. These are the examples of exogenous toxins. Next comes the fourth one, traumatic uveitis. It is often seen in accidental or operative injuries to the uveal tissues. Different mechanisms which may produce uveitis following trauma include, so traumatic uveitis means followed by a trauma. After a trauma, there occurs a uveitis, that is traumatic uveitis. Direct mechanical effects of trauma. Due to the direct mechanical effects of trauma or irritative effects of blood products after intraocular hemorrhage. After trauma, there is a hemorrhage inside, that is intraocular hemorrhage. Irritative effects of that blood products. Irritative effects of that blood products in the inside the eye can produce traumatic uveitis or microbial invasion. After this trauma, there is a chance of getting microbes inside. Like that, uveitis can come, or chemical effects of retained intraocular foreign bodies. After trauma, if some foreign bodies will get and stuck there, that can cause the chemical effects. That means the chemical emitted from that discharge from that foreign body can cause uveitis, or due to sympathetic ophthalmia in the other eye. So these are the causes for traumatic uveitis. So after the trauma, there is a chance of getting invasion of microbes, or this foreign body will cause some chemical effects, or this blood will get collected inside the eye, and that can cause uveitis, or direct mechanical effects of the trauma can also cause uveitis. Next comes the uveitis associated with non-infective systemic diseases. That is, certain systemic diseases frequently complicated by uveitis include sarcoidosis, collagen-related disease, that is polyarthritis nodosa, or disseminated lupus erythematosus, rheumatic and rheumatoid arthritis, metabolic diseases like diabetes mellitus and gout, diseases of the central nervous system like sclerosis, and disease of the skins like psoriasis, lichen planus, erythema nodosa, uh, pemphigus, and so on. So these systemic diseases can cause secondary uveitis. So idiopathic uveitis, that can be divided into specific and non-specific causes. So that is also, the causes are unknown. Idiopathic uveitis. So which condition certain specific characters of their own, pars planitis, sympathetic. So there are two varieties in idiopathic uveitis, that is specific and non-specific type. So almost more than 25% of cases of uveitis fall in this non-specific idiopathic uveitis, which do not belong to any of the non-etiological group. So before this idiopathic, we learned 5 types, right? 5 etiological uveitis that won't belong to these 5 types will come under that, and almost 25% of uveitis what we are getting comes under this idiopathic uveitis. So these are the etiology of uveitis. Next comes the pathology of uveitis. Pathological classification. In the classification, there it's mentioned, right? Pathology of uveitis. It can be divided into two: separative and non-separative. Again, this non-separative can be classified into granulomatous and non-granulomatous. So the inflammation of uvea fundamentally has the same characteristics as the other body tissues, like there will be vascular and cellular response like the inflammation in any other part of the body. But due to the more extreme vascularity in the uveal tissue and looseness of the uveal tissue, the inflammatory responses are exaggerated in this part. Pathologically, we learned this one before. Separative, non-separative. Non-separative can be classified into granulomatous types and non-granulomatous type. So we can say pathology in 3 headings: pathology of separative type, and pathology of granulomatous and non-granulomatous type. In that first one is pathology of separative uveitis. Here, the purulent inflammation of uvea is usually associated with endophthalmitis or panophthalmitis, occurring as a result of exogenous infection by pyogenic organisms, which include Staphylococcus, Streptococcus, Pseudomonas, Pneumococcus, and Gonococcus. So here the purulent inflammation or separative means there is involvement of bacteria or pyogenic organisms, right? So here the inflammation is purulent or separative uveitis is mainly seen along with as a part of endophthalmitis and panophthalmitis, means whole eye is involved. There it is mainly due to the exogenous infection from outside. The infection is coming with the pyogenic organisms like Staphylococcus, Streptococcus, Pseudomonas, etc. The pathological reaction is characterized by outpouring of purulent exudate and infiltration of polymorphonuclear cells of uveal tissue, anterior chamber, posterior chamber, and vitreous cavity. So, like all other inflammation process, here also there will be infiltration of polymorphonuclear cells, and the outpouring of purulent exudates. There will be purulent exudate collection where all it is seen in uveal tissue, anterior chamber, posterior chamber and vitreous cavity. And as a result, the whole tissue, uveal tissue is thickened and necrotic and the cavity of the eye become filled with pus. So, because of this, so the pathology of suppurative uveitis is mainly with endophthalmitis and panophthalmitis. The organisms like pyogenic organisms like Staphylococcus, Streptococcus, etc. will cause this disease. And here what will happen, there will be infiltration of, if the organisms, microorganisms will come, a foreign body came, so there will be infiltration of polymorphonuclear cells and these exudates are outpoured or emitted into the structures, surrounding structures from this uveal tissue. So there will be outpouring of exudates of uveal tissue, anterior chamber, posterior chamber and vitreous cavity. And as a result of this, there will be thickening and necrosis of this uveal tissue and the cavities of the eyes will be filled with pus. That is the pathology of suppurative uveitis. Next comes the pathology of non-suppurative. There, first one is non-granulomatous uveitis. It is mainly uveitis may be acute or chronic exudate inflammation of uveal tissue, usually occurring due to either to a physical and toxic insult to the tissue or a result of hypersensitivity reaction. So, due to a physical or toxic insult to a tissue, to the uveal tissue, or due to the hypersensitivity reaction, this non-granulomatous uveitis can occur. So here, pathological changes of non-granulomatic reaction consist of marked dilation and increased permeability of vessels. So pathology of non-granulomatous, first thing is marked dilation of blood vessels and permeability will also increase. And there will be breakdown of blood aqueous barrier. So breakdown of blood aqueous barrier. There is some barriers, blood-brain barrier like that. Inside eye, there is blood aqueous barrier. So first there will be dilation and the infiltration, permeability of the vessels. After that, this blood aqueous barrier will break and exudates will be outpoured and infiltration by lymphocytes, plasma cells and large macrophages of uveal tissue, anterior chamber, posterior chamber and vitreous cavity. So again there is a infiltration or infiltration of polymorphonuclear cells. So there will be dilation, then permeability increases, then there will be breakdown of blood aqueous barrier and exudates are outpoured and there will be for sure infiltration of polymorphonuclear cells. As a result of this, the iris become waterlogged, iris become edematous, swollen iris, muddy with blurring of crypts and furrows. So this crypts and furrows we can't see. So mudding of crypts and furrows. Next, as a consequence, its mobility is reduced. So pupil will become, the size of the pupil become small due to a sphincter irritation and encroachment of radial vessels and exudates and lymphocytes poured into the anterior chamber. This exudates will poured into the, is secreted into the anterior chamber and there will be aqueous flare. Aqueous flare means in this aqueous chamber, these exudates will float. If we see through the slit lamp, we can see it as a flare. So it is known as aqueous flare and deposition of fine capes. Cape means keratic precipitates at the back of the cornea. At the back of the cornea, there will be dot like muddy, sticky things behind the cornea. That is cape. That is keratic precipitates can be seen. That is nothing but this exudates only. Because of this infection, this exudates coming out. Due to the exudates in the posterior chamber, the posterior surface of the iris adheres to the anterior capsule of the lens leading to posterior SHALAKYA formation. So due to the exudates in the posterior chamber, so this anterior segment is divided into anterior chamber and posterior chamber by iris. So this exudates in the posterior chamber will cause this iris to get stick in the lens, will get stick to the lens. So because of that, that is known as posterior SHALAKYA. Normally, the lens is here, the iris is there, in between a space is there, that will form the posterior chamber. But in this exudate secretion, this iris will get attached or adhered to the lens anterior capsule, and there forms the posterior SHALAKYA, that is posterior SHALAKYA. And in severe inflammation due to pouring of exudate from the ciliary process behind the lens, an exudative membrane called cyclitic membrane may be formed. So, if the exudates are more from the ciliary process, it is secreting more, then behind the lens one new membrane will form, that is known as cyclitic membrane. After healing, pinpoint areas of necrosis or atrophy are evident, and subsequent attacks leads to atrophy, gliosis and fibrosis, which cause adhesion, scarring and eventually destruction of eye. Atrophy, gliosis is the damage of glial cells in the central nervous system. So there is a nerve damage, okay, there will be nerve damage, and there will be fibrosis, and at last there will be destruction of eye. So this is the pathology of non-granulomatous uveitis. So nothing like other inflammation. Here also there will be dilation of the blood vessels. Then this permeability will increase, and all these polymorphonuclear cells will come, and this blood aqueous barrier will break, and there will be inflammation, and exudates will come to the uveal tissue, anterior chamber, posterior chamber, and all. And as a result of this, there will be thickening of iris. The iris will become edematous, and the scripts will become muddy, because of the edema we can't see the crux and furrows. And as a consequence of this, what will happen, the pupil can't move properly, so pupil looks small, and exudates will get collected in the anterior chamber, and that causes the formation of aqueous flares. Aqueous flares is nothing but these deposits will move in the anterior chamber, and KP is keratic precipitates, that will these exudates will go and stick behind the cornea. Like in glass, if mud will get stick like that behind the cornea, these exudates will go and stick. That is known as keratic precipitates. This due to this, in the posterior chamber, what will happen, the iris will get stick in the lens, that is known as posterior SHALAKYA. And similarly, a separate layer will form behind the lens with these exudates, and that is known as cyclitic membrane. And after healing, there will be necrosis, atrophy, gliosis, and at last there is a chance of, if not treated, there is a chance of destruction of eye. Next comes the pathology of granulomatous uveitis. In granulomatous uveitis is mainly occur, it's a chronic inflammation of proliferative nature, which typically occurs in response to anything which acts as an irritant foreign body, whether it be inorganic or organic material introduced from outside, a hemorrhage or necrotic tissue within the eye, or one of the certain specific organisms of non-pyogenic and relatively non-virulent character. So this granulomatous uveitis is mainly due to irritant foreign body. It can be from outside or inside. So inorganic or organic material. A hemorrhage or necrotic tissue within the eye, that is inside, right? Hemorrhage or necrotic tissue within the eye, or some specific non-pyogenic organisms, that is less virulent organisms, that is causing uveitis. These are the reason for granulomatous. Okay, there is no pyogenic formation, that's why less virulent organisms or any hemorrhage or necrotic tissue already inside the eye, these all can cause granulomatous uveitis. So the common organisms can be tuberculosis, leprosy, syphilis, viral, mycotic, protozoal, helminthic infections, all. So these organisms, but they are less virulent. A typical granulomatous inflammation is also seen in sarcoidosis, sympathetic ophthalmitis, Vogt-Koyanagi, Haradas disease. So here in granulomatous uveitis, the pathologic reaction in granulomatous uveitis is characterized by infiltration with polymorphocells, that is lymphocytes, plasma cells, and all, and with the mobilization and proliferation of large mononuclear cells which eventually become epithelioid and giant cells and aggregate into nodules. Like other inflammation, here also there will be infiltration of polymorphonuclear cells, and all this will joint and form a epithelioid and giant cells. These all will forms a giant cells and aggregate into nodules. It will form nodules, these cells. That iris nodules are usually formed near the pupillary border, the border of the pupil. That is known as Koppe's nodule. So this all cells will form epithelioid giant cells, and these then forms into a nodule, and it can be seen in the margin of the pupil, that is pupillary border. That is known as Koppe's nodule. Similar nodular collection of the cells is deposited at the back of the cornea in the form of mutton fat keratic precipitates and aqueous flare in minima. This we saw in non-granulomatous uveitis. There will be KP. KP is keratic precipitates, and aqueous flare can also be seen. Necrosis in the adjacent structures lead to a reparative process resulting in fibrosis and gliosis of the involved area. So there will be necrosis, fibrosis and gliosis of that involved area. So this is the pathology of granulomatous uveitis. Granulomatous uveitis, what will happen? All these polymorphonuclear cells will get collected and a giant cell is formed, and it will get aggregate into a nodule, and it can be seen in the pupillary margins, that is known as Koppe's nodule, and there will be presence of KP, keratic precipitates, and aqueous flare in the aqueous humor, and also after that there will be necrosis, fibrosis and gliosis of that involved area. This is the pathology of granulomatous tissues, granulomatous uveitis. Okay, so this is uveitis. This is about uveitis, classification, etiology and pathology. In the next class, we'll deal with anterior uveitis. Uveitis as a separate types. Anterior uveitis. Next class, we'll deal with that. Hope you understood this much. This is a vast portion, and try to listen to that again and again separately. First you try to understand the classification, then etiology, then pathology. Part by part you do by yourself. Okay, thank you.